Good afternoon, everyone. I'm Stanley Brown. I'm the Dean of the Dalalana School of Public Health, and I'm glad that you're all here today for this really important discussion. Before we start, I'd like to make sure that we do the land acknowledgement. So we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Look, I want to welcome everyone to a very special event today at the Dalalana School of Public Health. This is one of our Boehm Lectures on public health and healthcare. And the goal of these is to really highlight and foster dialogue that leads to action on some of the most important issues facing our public health and healthcare systems today. I want to send a very special thanks to Les Boehm for his support of this and many other things at the school. It's in partnership with donors like Les, who not only bring support, but also bring a vision for what they think could be better in our systems. It's through this sort of a partnership that we're able to bring impactful initiatives like these public lectures that aim to spark a dialogue on critical issues, engage the public health and health system communities, as well as other neighbors and partners across our city, across our province, across our country, and as much as possible globally. So the discussion for this afternoon is health policy for the Anthropocene. And discussion will feature health system experts as they examine what climate change really demands of the health sector. And although I think we know we're knowing more and more about the challenges presented by climate change, I think what you'll see now through the work of people like Fiona Miller, who's going to be our keynote speaker today, and panelists who are going to discuss this today, Andrew Pinto and Penny Ballum, you're going to see also the options of what we can do, that this is not something where we should retreat or fear some changes that could actually lead to a better system. So today's discussion, I think, will help answer the question, how exactly does climate change affect the health sector? And what can we do to reduce its negative effects on our health system? We'll explore ways in which climate affects marginalized groups as they access the health system, and ways in which we will need to adapt to reduce healthcare's carbon footprint on our world. Discussion today is going to be moderated by my colleague and friend Ross Upshur. He's the head of the Division of the Clinical Public Health at the Dalalana School of Public Health, and a scholar with a number of achievements to his name. I've already noted our speakers today, but I just want to thank again our keynote speaker, Professor Fiona Miller, and our panelists, Dr. Penny Ballum and Dr. Andrew Pinto, for sharing their research, their expertise, and the solutions that each of us as individuals, groups, and organizations can really contribute to, can participate in, and commit to as we go forward. So without further delay, let me turn things over to Ross, who will introduce us to our panelists and get us started. Thanks, Ross.
Thank you, Stanley. It's a really great pleasure and honor to be the moderator of this panel. And this particular Boehm lecture couldn't be more perfectly timed, particularly in light of the release of the 6th report of the Intergovernmental Panel on Climate Change in February 2022, which really, I think, had some sobering advice for the global community. So without further ado, I'm going to introduce our keynote speaker and panelists, and then hand over the microphone. So our keynote speaker today, I'm delighted to introduce, is Dr. Fiona Miller. And Fiona is a professor of health policy in the Institute of Health Policy Management and Evaluation at the Dalalana School of Public Health. And she holds the chair in health management strategies and is also a Keynote scholar. She directs the Center for Sustainable Healthcare Systems at the U of T and a national initiative for climate action and awareness in healthcare called Cascades. In these roles, she leads and supports efforts to improve the sustainability of health systems through research, education, practice change, and policy advocacy. As a policy scholar, Dr. Miller brings a critical political economy perspective to the analysis of technological innovation and sustainability transitions. Her aim works at sustainable, demand-driven innovation. Following her keynote, we will have two commentaries. The first will be from Dr. Andrew Pinto. Dr. Pinto is the founder and director of the Upstream Lab, a research team focused on tackling social determinants, population health management, and using data to enable proactive care. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He is a public health and preventive medicine specialist and family physician at St. Mike's Hospital in downtown Toronto, and an associate professor at the University of Toronto. He's also the Associate Director for Clinical Research at the University of Toronto Practice-Based Research Network called Utopian, and the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. And last but not least, we're really privileged to have Dr. Penny Boehm. And she was appointed as chair of the board of Vancouver Coastal Health in January 2019. She's a clinical professor of medicine at the University of British Columbia and a fellow of the Canadian Academy of Health Sciences. She's had a distinguished 35-year career as a leader in healthcare and an academic clinician in British Columbia. She served as the Deputy Minister of Health in British Columbia from 2001 to 2006, and also served as the City Manager of Vancouver from 2008 to 2015. She has extensive board experience, served on public sector, nonprofit, and private sector boards, and has received significant public recognition for her work in medicine and public service, including the Queen's Golden Jubilee Medal for Public Service, the 2012 Wallace Wilson Award for Leadership, the Marion Powell Award from Women's College Hospital for Leadership in Women's Health, the Cannell Award from the Society of Obstetrics and Gynecology of Canada for her contributions to leadership and reproductive health, and many others. She advises governments across Canada on health policy, health systems, and human health resources, and is a much admired colleague in the IHPME DLSPH community. So a distinguished panel and an excellent keynote speaker. And without further ado, I'm going to hand it over to Dr. Miller. Dr. Miller?
Thanks so much, Ross. And I want to put out a personal thanks to Les Boehm for sponsoring this lecture series. I have the privilege of working with Les and really appreciate the work that he does to support Dalalana and to help us to bring issues like this to you. So I just want to set the stage for our conversation by starting with an image, one of many, that tries to characterize the nature of the Anthropocene, which is really sort of an argument that humans have become such a powerful and dominant force on the planet that we create the conditions in which we live. So welcome, as it were, to the Anthropocene. Get comfortable, because we are going to be here for a while. Now, I know as I say that we technically are not in the Anthropocene. That's not an accepted scientific term for one of the geological eras or epochs within which we live. We're technically within the Holocene, which is less than 12,000 years since the last great ice age. This is here, the actual map of the geological history of the planet. You can see this small sliver of time within the 4.7 odd billion years of our planet that defines the Holocene where we are. And the argument of the Anthropocene is that an even smaller sliver of time is actually best understood, not in terms of geological processes, but by us in terms of the impact that we are having. And of course, there is considerable evidence of that. Ross already pointed to this. This is the Intergovernmental Panel on Climate Change. This is actually their report from Working Group 1 last August, which synthesized the physical science evidence of climate change and shows quite clearly that it is us. I'm not going to show you much from this, but just this image is probably fairly useful. So if climate change was caused by natural phenomena, solar events, volcanic activity, we would expect to see a temperature increase that sort of really stays around zero, i.e. no major increase in global mean temperature. What we're actually seeing is this. We have an estimated 1.1 degrees Celsius increase in mean temperature globally. And regionally varied, Canada is warming at almost twice the global average. But this is what we see. Climate change is anthropogenic. But it is not only climate change, as many of us are fully aware. There are many other ecological challenges, land use changes, and challenges for biodiversity, challenges for our soils, which are compacted and salinated, affecting pollution of various sorts, and all sorts of pollution, including plastics pollution. So the concept of planetary boundaries has been introduced by the Stockholm Resilience Center more than 10 years ago as a way of trying to understand the range of these anthropogenic challenges that exist within our biophysical systems that really do challenge our ability to continue to live safely on this planet. So here are 9 domains. And the safe operating space is in the middle. This is actually their updated chart from earlier this year, when they released research suggesting that they had been able to map the boundary and where we are relative to the boundary for novel entities, chemicals and other plastics. So this is an idea of the kind of challenges that we face. But none of us here are Earth system scientists. I'm not a geologist myself. I think we're here to talk about the connection to health, to public health and health systems. And I want to draw that connection, focusing in particular on climate, which does have such a universal impact and such a compounding impact with all the other ecological threats, but remembering always that it is not the only challenge before us. So what's the link? There are really four, I think, ways of thinking about what's the connection between climate and health. The first is that climate change impacts our health, and we have virtual certainty in seeing that the impacts will be negative, largely negative. Now, the thing about climate change and the greenhouse gases that contribute to it is that the greenhouse gases are not themselves toxic. So they do not affect our health just through the emission of greenhouse gases. They work through complex pathways. They work through temperature rise and sea level rise and the increase in extreme events. So those extreme events, floods, droughts, heat waves, wildfires, can cause direct injury and death, but more of the health harm flows through other pathways that affecting agriculture, biodiversity, air pollution, and therefore affecting our health through things like malnutrition, impacts on mental health, cardiorespiratory disease, and of course, infectious diseases, in particular, vector-borne infectious diseases, such as the increasing migration of the endemic nature of ticks in Southern Ontario that carry Lyme disease. And all of these health impacts, of course, work through social systems. So whether we have a prior risk, whether we are particularly vulnerable, whether we have the capacity to respond and recover, all of these are socially mediated, and they are unequal and inequitable across and within countries. The second link between climate and health is actually the sort of positive flip side, that if we tackle the root causes of climate change, we can both achieve the benefits of reducing those health harms, but also achieve immediate health co-benefits, it's termed. So a good example of this is air pollution and its impact on non-communicable diseases. Now, a major cause of air pollution is, in fact, the burning of fossil fuels for transportation and energy. So if we were to cut out the burning of fossil fuels for those purposes, we would both contribute to the improvement of our health by mitigating climate change and contribute immediately to the improvement of our health through removing air pollution from our cities and communities, which is a huge impact on health. The other set of links really are to health systems. And the first is that all of these climate-related events do negatively challenge health systems to a substantial extent. So acute shocks, for example, a wildfire that requires a hospital to be evacuated, reduces your capacity, but it also creates surges in demand. Now, Penny Boehm, the chair of the board of Vancouver Coastal, can speak to this with more authority, and I'm sure we'll get into this in our discussion, but during the heat dome last summer, in British Columbia, there were so many people needing treatment for heat-related conditions, they had to cancel surgeries. But the stresses aren't just acute, those are very real. The stresses are also chronic. You can have an extreme high heat day, as we had in Lytton, BC, but you can also have days and weeks of high heat, which is something we're going to be seeing in Toronto increasingly. And these are stresses that are chronic on our capacity to operate, on our buildings, on our facilities, on our workforce, and of course also affecting individuals and communities in terms of the needs that they have for care. The fourth connection is sort of the ironic truth that healthcare is itself a contributor to the climate challenge. It is indeed a highly resource intensive and polluting service sector. And here's an image from the Lancet Countdown on health and climate change that just tries to characterize the per capita carbon footprint of different health systems around the world. So the sort of carbon intensity, if you will, of our healthcare. And what you'll see here is that all of the rich countries are really quite carbon intensive. The rest of the world that needs to build more healthcare capacity for their communities is very low. So we need to build that capacity around the world without increasing the carbon impact of that care. And for those of us in Canada who are sort of health policy oriented, will be familiar with the narrative that we are saved from last place by our neighbors to the south. The United States is the most carbon intensive health system, and we are, by this accounting of 2021, the second. Here's an image that I love that tries to sort of characterize what I'm talking about when I say that healthcare is incredibly climate and resource intensive. This is Dutch spatial artist Maria Koik. And this is the artwork that she made that's really quite beautiful, as well as being slightly horrifying in mapping out and putting together all of the materials required from her surgery and anesthesia. So think about all of the energy and all of the resources required to develop and transport, to use and dispose of all of these materials, all of the procedures, all of the processes, all of the organizations, everything required to do this. Very, very resource and climate intensive service sector, and we will need, I would argue, to reduce that. So that's where we turn to the health policy question. What must we do? So very intentionally, these are images from British Columbia, because I think that has been a real wake-up call for those not attending to it. Our colleagues in British Columbia were preparing, they're quite well prepared, set of health authorities and health systems for these events, but they still weren't prepared for it happening last summer. So at the top there, the heat dome, supposedly 1 in 1,000-year event. These will happen more frequently, and the associated wildfires. And then the atmospheric river in the fall and the associated damage to infrastructure. All of these things call, therefore, for really an immediate response. There are things we need to do next Tuesday and tomorrow and today, as they say, in terms of responding to this. And I think we will probably spend the most of our time this evening, this afternoon, talking about these issues. And I would argue that we in the health policy world, in applied health policy, health services, public health, will increasingly be attending to this to some degree as researchers, as teachers, as leaders, as managers, as governors. So what must we do? Well, the first challenge is that of adaptation and resilience, is equipping ourselves to face the climate challenge. An important thing to understand about climate change is that we are locked into greater warming. We currently, as I told you, are at 1.1 degrees Celsius mean increase. The projections, all the models suggest that we will reach 1.5 degrees, perhaps 1.6 degrees in the worst case scenario by 2040. That's a point estimate ranging from 1.2 to 1.9. But we are on track. It's sort of locked in. Even the most radical mitigation measures today or tomorrow will not particularly change that. So we are locked into increased heating. And as I said, Canada is warming at approximately twice the global average. So there is clearly a need for adaptation and building resilience. So some of this is classic public health, understanding how communities around the country and around the world are going to be challenged, what their vulnerabilities are, and what adaptation is possible and necessary, because climate change is experienced locally. Part of this is hardening our health systems, our facilities, certainly, our workforce. How do we organize services so that dialysis patients can get the care they need, even in the event of an emergency, that patients who need access to medications, perhaps on a daily supervised basis, will be able to get it, so that our facilities can serve as refuges, so that the excellent and essential work that we do can continue. And here I just give one image that points to also the ways in which clinical care will need to adjust in some way, certainly more learning. So extreme heat being a good example that will affect clinicians in acute care and community care. In community care, checking on people to find out whether they're particularly vulnerable, what their exposure is. If one is prescribing medications, understanding whether those medications increase the individual's risk, because many commonly prescribed medications are diuretics, or they reduce thermoregulation of the ability to manage heat. So there's many things that I think these are the non-optional changes. We will have to do this. When it comes to the flip side, which is reducing the climate and broader environmental harms of care, I think this is a moral imperative. I think this is something we can do, but obviously we will have to decide and debate this. But what I want to show here are that we are well placed to do this, and increasingly well placed. We have global leaders. So the image there is from the English National Health Service, which in October of 2020, in the middle of the pandemic, put forth their commitment to become a net zero National Health Service, the first in the world. Their commitment is to 2040 for directly controlled emissions, and to my mind, even more ambitiously, 2045 for indirectly controlled emissions. And they reported last fall, their first year of activity, that they are on target to do so. What I have here, this image below that is from my colleague Andrea McNeil, who works with Dr. Penny Boehm in Vancouver Coastal, director of the Planetary Healthcare Lab at UBC, and a really lovely conceptualization of what she calls planetary healthcare, helps us to understand what's involved in reducing the environmental harms of care. And some of it it's very basic in many ways. How do we improve health? How do we reduce the demand for health services? Then how do we match supply to demand? How do we ensure that the care is appropriate? How do we steward that care? How do we rebalance, in a sense, and emphasize primary and community care services where and as we can? And then how, for the remaining things we supply, do we reduce emissions? And facilities are in there, drugs, devices, technologies, issues like that. And then the image to the right, this is from the Climate Change Conference in Glasgow last fall, the COP26 Conference of Parties, when health and health systems were really featured very prominently. And there was a health program calling for countries to commit to delivering and developing a climate resilient and low carbon sustainable health system. And the government of Canada did sign on. So I do think that there is growing momentum and interest and, as I say, capacity to deliver on this agenda. So as I say, I think much of our conversation this afternoon will be about those very immediate and practical issues we must pursue. But as a policy scholar, I do want to suggest that there are some other things that are perhaps health policy 2.0 that we will increasingly need to consider. Everything that I've just talked about in terms of what we must do really presumes the world as we know it. We're talking about a health system as it exists, and a world that, yes, is heating, but remains in many ways fundamentally the same. But it's not clear that that's a fair prediction. And I would argue that we're going to need to, in addition to the applied health policy of addressing these challenges, we'll need to start thinking and acting on new opportunities. So to do that, to begin to reflect very briefly, let's look back, let's think about the history and how public health and health systems have been part of building the world that we're in, so that we can reflect forward. So I'm introducing here an image. Actually, it's from Emmanuel Saez, but it's modified from Piketty's work. And it's a really lovely image, I think, about what they call the social state. So what is this image? This is an image that across several European countries talks about how much of the national income has been used for government spending. And so this steady growth from the early 20th century until sort of the neoliberal turn, if you will, towards the end of the 70s. So what's going on here? What's going on here is the state expands from this sort of minimalist night watchman state with basic administrative capacities, police, warfare, things like that, and starts to expand in the delivery of collective social services and social needs, addressing social needs collectively. Gathering resources through political battles that were hard fought in order to build these social services. Not recorded in this chart, but those of us who know public health know well that a big part of what had to be built in the 19th century in particular was the fundamental public health infrastructure, sewerage, and potable water, and then the increase of additional critical social services that make our lives for most people, make our lives, give us well-being, sorry. So education, healthcare. So healthcare is here. It's not the only piece here, but healthcare is a very important part of what's being built here for a couple of reasons. Health is one of those sort of globally valued moral ends. Health is a difficult thing to argue with, and healthcare has been one of those social services, universal social services that attracts a lot of public support. It's generally understood to be an area where care should be provided in accordance with need. And indeed, Canada is interesting in this regard because we have a particularly strong form of universalism, certainly at the core of our publicly financed health system, the Medicare core that is consistent or fairly consistent across the country, that is the medically necessary physician and hospital services. Our system is so universal in its orientation that it indeed attempts to prevent access to these forms of care other than on the basis of need. So that's where we've been. And what does that mean about where we are going? And what does it mean about the role of public health and health systems in the future? And so there's obviously much debate about what the future will look like. And it's not something that's readily resolved by evidence. And at least one division that is probably the dominant vision is that we will continue as we are. The Green Growth Vision does expect that we can continue to do what we do, to consume as we do, but we can decouple our growth from our reliance on resources and our climate impacts. But there is a significant contention that we cannot, that we will indeed have to fundamentally transform the way in which we engage in consumption, in resource use. And also we have the opportunity then for a sustainable welfare state, a new eco-social contract or eco-social state. These are the concepts where I think there's an increasing role for health policy to engage. Again, because health has a particular moral status. Public health and health systems are critical parts of the social state and will need to be part of what we build forward. So a couple of examples. Expanding what is provided under the terms of our healthcare system. Expanding because one can shift costs, but one can't shift carbons. There's a very strong argument for providing more services under the auspices of a universalist program and reducing the climate impact of that. Using our universalist model to understand how to expand more social services in a more universal way, and also engaging in the debates and discussions and research to understand how we will finance, govern, organize, and deliver these. We're talking about a potential shift in the way we structure work, welfare, consumption, and indeed our relationship with the environment. So I would suggest that in addition to the practical things we will need to do, we will need to be part of debates and discussions and research that understands what the opportunities are for a potentially quite different world we will wish to build. And I'll leave it at that and pass it back to Ross.
Yeah, thank you, Professor Miller, for an extraordinarily lucid presentation. And without further ado, I'm going to hand it over to Dr. Pinto.
Thank you so much. I really appreciate the privilege of speaking today and really thank the organizers for the invitation. I think what I'm going to offer to this discussion will resonate quite well with what Dr. Miller has said. And I hope it spurs some discussion and some questions afterwards. I'm going to focus my comments on really the power that health policy has in addressing these issues that we're familiar with and that really Dr. Miller covered really well, which is the crisis that is climate change and how it's impacting the health of people, but also all living things on the planet, really. Health policy really is this powerful tool that helps us define goals for our societies that are related to health, and also help specify what are the decisions and plans and actions that we think should be taken to achieve those goals. And it through the forming of health policy and through implementing it, we really clarify what are our values as a society, what is our vision, and really what are our objectives and what are our targets as well. In this context of a world that is being dramatically changed by human activity, it's interesting that the way that we phrase the Anthropocene is as seeing humans as a dominant force. One of I think my reflections on this is actually thinking a little bit about the idea of dominance and the way in which, if we think about a healthy individual or a healthy community, it's not an individual community who is dominated. In fact, in my clinical work, when I work with patients, if people are actually the victims of domination by their circumstances or by other individuals, it's incredibly unhealthy. So I think part of at a very high level, it's about rephrasing the way that and rethinking the way that we see ourselves in relationship to the world, and actually trying to extricate ourselves from the idea of dominance. And it's and of course this actually is really hard because we're all embedded and have grown up and have been educated in a context where we do see humans as dominant. So let me cover kind of three areas. One is what has shaped health policy and what can shape it. What is health policy's role in dealing with crises? And what are some of the solutions that health policy could offer? So on the first, health policy is really a product of and embedded in social, political, and economic context. And that's something which Fiona, touched on briefly, is that the world that we're in right now is not necessarily the world that has to be and the world that we would want to see. The context in which we're in is characterized by a political system that is very short term. So we have governments that come into place and within 2 to 3, maybe 4 years are facing re-election and having to scramble. And it's an incredibly short time cycle. We are, of course, in an incredibly polarized world in terms of people's views on different things. And social media over the last decade and a half or so has really accelerated this polarization. We're in this strange context of having vast resources, but a feeling of great scarcity. And those resources are being distributed in a way that they're getting concentrated amongst a small fraction of the population at a very high rate. So things like wealth inequality have worsened dramatically over the last few decades. And underpinning a lot of this is the economic context in which we find ourselves, the advanced capitalist system in which we are, which tends to focus on a few key things: individual responsibility, that you're in it by yourself, and that the market actually is the solution to many of the problems, and that governments or collective action are inefficient and unable to solve problems. So if this is our context, this shapes the way that we think about problems. As an example that we're living right now with COVID is that we've shifted from the start of the pandemic 2 years ago, where there was a great focus on collective action, collective responsibility, that we are all in this together, and that what was widely accepted was public health measures. So measures that affected everybody: travel restrictions, restrictions on businesses, on education, on gatherings, and people really did engage with it, and there was buy-in. To today, where we actually are seeing our public health leaders focus on individual actions. So the individual decision to wear a mask or not, to get together with others. And it's a very interesting and kind of unfortunate parallel to the point where I recently saw someone characterized it as having a budget for risk and how much am I going to spend on certain risky behaviors. So you can see how this idea of thinking of individual responsibilities shape the way that we think about policy solutions. And a kind of a classic example for the climate crisis is that focusing on individual action. So do I choose to recycle or not? Do I choose to take the car or not? And that kind of focus on individual responsibility for the climate crisis is, I think, part of our economic system and part of the problem. Of course, related to this is that the Anthropocene and the climate crisis is being dramatically driven by economic systems and by the desire to profit, and for that profit to really accumulate in the hands of some people. So this is not only in the case of, say, oil extraction and the use of fossil fuels. It also is at the root of things like pollution and how we tolerate the pollution of oceans and lands, and really to who's benefiting from that. It's related to the way we engage in agriculture and in fishing. It relates to then the ways in which we lack the ability to respond to things like heat waves, floods, fire, and food insecurity. So the other aspect of, I think, the context that's so important is it also shapes who is considered an authority and where knowledge is. And I'll come back to that a bit later. So health policy and solutions we think of to these problems are shaped by the context, which is also forming and at the root of the problem. So my second kind of point is how health policy can play a crucial role in addressing crises. So similar to what Fiona mentioned briefly, is that health is a strong goal of our society. So this is kind of the glimmer of hope. Health is a collective good. It's something which here in Canada, we really do embrace, and it's kind of manifest in our universal, a principle of universality in our healthcare system, which of course has its limits, and it's not universal truly for everybody in our society, but it is still kind of a strong principle to draw on. And so imagine that this kind of focus on building health is actually becomes the goal of health policy, and that actually that is part of the solution to the climate crisis. So rather than a strong focus and emphasis and the way that we judge our performance of our governments being focused on things like GDP growth, a focus on employment and wealth creation, rather it being focused on health and how that health is distributed. Now, this may seem, incredibly idealistic, but let me draw on a few good examples where health policy actually played, and the way of thinking of health as a shared goal played a really powerful point. One is actually an old example from the 1980s, during a key point of the Cold War, when health professionals on both the US side and the Soviet side came together and said that there's no medical solution to a nuclear war, and that health is a common goal of both of our societies, even though we're very divided. And so International Physicians for the Prevention of Nuclear War was able to make this argument. And it led to collaborations and actions that actually helped diffuse tensions. And they won the Nobel Peace Prize for it in the 80s. And it's a very strong example which has actually continued and popped up as health professionals focusing on health as a common goal, even in the context of a very heated war. And of course, the war that is happening right now in Ukraine is a good example that brings this to mind as well. of what is the shared goal of even, two warring sides. Another kind of example, I think, that comes to mind of also taking on this challenge in health policy, playing a crucial role in a crisis, is actually the tobacco crisis. So there are some really strong lessons that we can draw on from the role of public health, academics, and health professionals in opposing big tobacco. And there's a whole, fantastic body of work, including by colleagues here at Dalalana, around the commercial determinants of health that we can draw on when it comes to thinking about the climate crisis. I think the third example, of course, that comes to mind is COVID itself. So during the pandemic, health policy in this crisis has played a key role, not always really the best role it could play, but let's take a look at inequities during COVID. We know that it was anticipated that there would be deep inequities in who was affected by the pandemic. It took community organizations and activists to push governments to collect information, to highlight these inequities, and then use that data to create actions. But it did lead to reductions in inequities. There's still much more work to go, but I think it's a good example that's actually from right here in Toronto and in Ontario of the power of a really well thought out health policy that's engaging communities and is driven by data to actually confront a crisis. I think some of the challenges health policy face is getting outside our usual way of thinking, being really bold and ambitious, and connecting with others in this space, and actually drawing on other areas of work and thinking as part of the solution. So let me come to my last points around what are some solutions and how can health policy play a powerful role in addressing the climate crisis. So one is that point of actually bringing in an intersectional analysis to really build bridges with people working on things like social determinants, people who are working on anti-racism interventions, people who are working in Indigenous health and public health, people who are working on alternatives to capitalism and really focusing on public goods. So bringing these folks together and looking at the commonalities of our work and getting outside of our kind of academic silos, I think can be really a powerful part of the solution. I think we need to have root cause analysis alongside the mitigation efforts. So for every action that we take that is about mitigating the role or trying to change the world that we're in right now, where we have a very polluting health system that has a very large carbon footprint, we also have to be saying how much energy are we devoting to the root causes as well. A third is the power of community engagement. So we know that many of the communities that are most affected by the climate crisis have not been part of engaging in the solutions, and we haven't done a good enough job in that. But we know that Indigenous communities, racialized communities, in communities in low and middle income countries that are suffering the worst brunt of the climate crisis can be, really should be leading the discussions and leading the efforts in this. And then finally, taking a human rights approach to this, I think is incredibly powerful and part of the solution, focusing on basic necessities and how we achieve that, and how that can be part of really the solutions that we envision from a health policy perspective, I think are key. Thanks so much for the time, and I look forward to the discussion.
Thank you, Andrew, for those very perceptive comments and insights. And now I'll invite Dr. Boehm to speak.
Thanks so much, Ross. And thank you to Dean Brown, who I haven't seen for a couple of years. It's really wonderful to see you. Thank you to the Dalla Lana School for the opportunity to participate on this panel. It's such an important area. And, you know, just finally to acknowledge that I'm speaking from the ancestral unceded territories of our 3 host First Nations in Vancouver Coastal, in the Lower Mainland, the Squamish, Musqueam, and Tsleil-Waututh. And you know, our organization, Vancouver Coastal, is on an ongoing journey of reconciliation and cultural safety and understanding of, you know, how our history has so impacted them and their lives. You know, I have listened with great interest to Fiona and Andrew, who, you know, have spoken so eloquently of, you know, these big problems that we're facing. And, you know, when Fiona asked me to participate in this, you know, the sort of richness that I can bring to a discussion like this is really at a very practical level. I'm not an academic in climate change. My academic interests are, you know, specific to platelets and the blood, but I've had a lot of experience in, you know, positions in both government and outside of government and other health leadership roles, where, you know, I've learned in I think the School of Hard Knocks, and, you know, have been through many things over nearly a 40-year career now. And, you know, I think what I'd like to do is just share some of the more practical things that, you know, I think it's so important for our sector to be aware of and to be able to play our critical role in addressing, you know, the many things that we're challenged with in this world, and particularly the, you know, the really devastating future with regard to climate change. The health sector is, you know, a very powerful sector. We have a lot of privilege, a lot of legitimacy, a lot of power, both as an entity, but also as leaders, and particularly, you know, the profession of medicine. Physicians are extremely powerful advocates. They have access right to the top of the power structures in our world, and I think that one of the first things that we need to recognize is that we have to be aware of our impacts, both our impacts, you know, on climate change, just of our, you know, our output of carbon and pollution. I think the net impact of the health sector in the world on climate change is we account for about 4.4% of, you know, the carbon footprint, the net carbon footprint in the world of everything. So it's very, very significant. So understanding our impact of our own sector on climate change, and as Fiona has touched on, you know, mapping out our journey of how we're going to change that. And along with that, you know, because in Canada, we are a publicly funded healthcare system. We benefit from remarkable philanthropy, from donors to our foundations. And, you know, we do have other opportunities to leverage, but nonetheless, we could remain helpless and hopeless in the context of, well, our government won't fund us to do this and won't fund us to do that. But I think we need to use our collective wisdom, some of the incredible resilience that we've demonstrated over the last 2 years during the COVID pandemic, and actually, you know, do our job to set out a practical plan that will move the dial in very meaningful ways around our climate impact, and, you know, take responsibility for our share of the issue, and help our funders, our public, our governments, our donors understand why these things that we need to do are important, what role they can play, and how we can show that we're being extraordinarily responsible in the use of our resources. And, you know, I always like, for people who've worked with me, I I love Scrabble, and I'm always looking for the triple and quadruple word score, where you can advance a quality care agenda, you can mitigate climate change, you can save money, and you can all feel much better about yourselves and how you're being a citizen in the world as you do these things. So as we plan our way forward in terms of mitigating the impact of the health sector on climate change, I want all of you to be looking for the quadruple word score. I think the other thing that we really need to understand, and as Fiona described, we've had a heck of a year in British Columbia. We had the heat dome, which basically killed hundreds of people in our province, and particularly in the Lower Mainland. And I can tell you, it was a devastating. It was just a shock. It was worse than COVID. We were all shocked and just felt completely taken aback by, the rapidity and the steep curve of impact of those few days of really devastating heat in a province where, particularly in the Lower Mainland, we're a pretty temperate climate, and we don't have the wide swings that the rest of the country even are exposed to. I grew up in Quebec, and part of the reason I left the East was to get away from that terrible heat in the summer and the mugginess. I actually love winter, but I don't miss -30. So, we realized we had some preparation for these things, but it was insufficient. And so, part of the responsibility of our sector is, to recognize a lack of preparation and to not dwell on the various inquiries that will go on, to participate responsibly and transparently, but really, what are you going to do about the next time this happens, and how can you enhance your resilience and preparedness, and how do you organize? How do we as leaders organize ourselves in our organizations, to actually have accountable individuals who are responsible for developing plans and others that are implementing them, and to actually project and performance manage those things. And as a board chair, it's very, very important for us not to just discuss what happened and why it happened, but more importantly, how are we going to improve our performance and the safety for our public the next time around, and then continue to improve it as we learn different things. And finally, just around us as a sector, as I said, we're very powerful. We have a lot of privilege, a lot of legitimacy. And, when we talk about things as a sector and the leaders in our sector, people take us seriously. And it's critically important for us to respond in kind. I think the other thing, we were asked a question on, how do we better prepare our leaders in public health for, responding to climate change and the various impacts on it. And I think COVID over 2 years has been a remarkable learning experience for us. As a deputy minister and a city manager, it's one of the things you learn very quickly. When something goes wrong, you're accountable, and you've got to make sure your organization is if it's not ready, that it's getting quickly ready, and that it's acting, and it's continuing to, revisit how it's all working, and, get ready to change course. And I think as we train our healthcare workers, our healthcare professionals, and really importantly, our healthcare leaders, there's attributes that we really need to think about. I think health sector, over my career, I think we've done remarkable things, but we do suffer from a little bit of insularism. And I think public health as an entity and a discipline is much more aware of the broader world and the impact of things that happen on things like the economy and people's well-being. But even at that, I think we have more to learn as leaders around, the clarity of our decision making, around the humility of not having all the answers, and not having all the assets and attributes to fix things, and being able to reach out and work with groups that we've never worked with before, and in fact didn't understand the amazing skill sets they can bring to solving a problem. And a quick example of that is we reached out to a number of organizations in the tourism industry who had all been laid off, and we integrated them for, you know, the sort of front end of our whole vaccination program. And they were remarkable with greeting the public, making them feel comfortable, getting them organized, queuing them, keeping them busy. And, you know, they were, I have to say that our healthcare workers across the province who participated in the sort of more clinical aspects of a vaccine clinic were quite taken aback at how effective these people who had worked in the, you know, airports and in the cruise ships and all these various industries where people management is their thing, and they taught us a lot. So being able to humbly see that we're not the only people with the answers, and we can leverage local governments who have many different areas of expertise and business lines, and our local business community and our nonprofit groups who probably we have you know, more interaction with. But I think understanding and actually developing those relationships on an ongoing basis, so that when we get into difficulty, like, you know, a fire combined with a flood that, you know, shut down parts of our province, completely you know, ransacked our supply chain capability, and actually forced you know, climate refugees to have to be evacuated out of long-term care homes, out of some hospitals, out of whole communities. And, you know, we had to play a role and figure out how to do that, you know, really with 24 or 36 hours notice. And if it weren't for, you know, the different relationships that we developed on the run, we never could have done that, whether it was with the transportation sector, with people in the hospitality industry, local governments, emergency workers of various sorts, nonprofit groups who specialize in emergency. And it's really, you know, our relationship, the importance of building relationships that are longstanding, where you can pick up a phone and call people, you know, and ask them to come together. And, you know, from I had the incredible privilege of, you know, going out of the health sector and working in local government. And I could tell you that's where I really recognized the criticality of, you know, the healthcare system and how it impacts our communities, and the role that local governments and different organizations play in helping support us in ways sometimes we don't even recognize. I think the other thing that we learned from COVID that we could apply to climate resiliency is, you know, how critical data is. And more importantly, it's one thing to have data and to report on it. It's a whole other thing to inform our actions and our ongoing plans and our, you know, the implementation of solutions, and have that informed by ongoing data. We talk about that all the time in healthcare, and yet I think we have a long way to go to have a system that is constantly informed by our own business metrics, our outcome metrics, and has the humility and the ability to adjust and nuance and you know, get more help, or, you know, develop, bring different people in to actually solve problems as we see them come forward. And, you know, I think generally across the world, COVID has showed us the importance of understanding, you know, all the basics of public health and epidemiology. What's your case count? Where is it happening? Who's it affecting? What are you doing about it? How is that working? You know, let's start over again. How is the virus, you know, evolving? And you know, to actually, if we did business as a sector like that on an ongoing basis, in regard to many different things, and particularly in regard to our response to the climate change that we're already being impacted by, it will really help us be more effective, so that, you know, evidence-informed quality improvement on a really ongoing basis. And you need leadership, you need good governance to actually make sure that that goes on. I just want to speak to some of, you know, really the reality of some of our groups that did suffer, you know, in an untoward way, and some of our successes as well. And I'm going to start with our Indigenous population, because I think all of us in this country, you know, with the kind of leadership that we have now, have recognized we have a lot of work to do to, you know, to reconcile with our Indigenous peoples, and, you know, to do with them and guided by them, and in a way that is culturally respectful and safe, basically as a healthcare system, do a much better job and provide them services that are not tainted by racism and disrespect and, a lack of cultural humility and an understanding. And, I think that generally in Canada, our public health leadership recognized the vulnerability of Indigenous peoples. That was absolutely, reiterated by ongoing real-time data. In British Columbia, it was very clear that Indigenous peoples in our province were hospitalized at a greater rate at all ages, at a higher mortality rate. And they were, and we had to adjust our vaccination programs to account for that in terms of, age cutoffs when we were short of vaccine. We lowered the age limit for Indigenous. But I think more importantly, we knew that the history of immunization and infectious disease in our Indigenous community was not one of which we could be at all proud. And we saw our communities, and we have 203 of them in British Columbia, terrified that this was yet another plague that they were going to be left fending for themselves. And I do think that across this country, from my understanding of many meetings I've been at and sharing collaborative practice across the country amongst the federal provincial jurisdictions and with our First Nations leadership, we did a better job. We knew they were going to be vulnerable. We got our vaccines in there. We allowed communities across Canada to create their own plans with our support and assistance and not a lecture of how they were going to protect themselves. And I think, it was not perfect. And we still have a lot to learn, but I would say the feedback that we've received for Indigenous leaders is they could feel the effort, they could feel the desire to do the right thing, but leave them in charge of their own destiny and to provide them access in a very appropriate, prioritized way to the kinds of tools that are so critical to protect themselves. And I think, that's something we need to really remember, because they will also be much more vulnerable to the impact of climate change. And we've already seen that. I think you all remember Lytton, which was, basically burnt to the ground in about 24 hours. A place where, as a deputy, I built a new hospital, just everything gone. Just a devastating thing to have happen. And, we're still kind of, dealing with, how do you come back from that, even that scale? So a lot of work to do, but lessons that we need to carry through, and relationships that have been built, and ways of working together, that we need to continue to do in every aspect of our interaction. And, children and youth, I think all of us learned about, just how critical it was to keep children and youth out of school for even a few months, and the critical importance of, advocating for and actually being nimble and resilient to figure out, well, how could we rebuild public confidence as public health leaders in, their children being safe in schools? How could we, find that balance point between that was informed by science, but allowed our kids to return to school? And it happened in different ways across the country and at different rates, but really, really important. And, women have been adversely and more disproportionately affected in this pandemic. And we know that, in climate change, it's the same story. So, many of the things that happened in COVID that were, an obvious, is actually part of the risk of climate change, we're going to build on. And finally, seniors, I think, of all the things that I saw in our own health authority that was shocking to all of the various leaders that we have amongst very many disciplines and responsibilities, it was really the impact on our frail seniors, and particularly in long-term care, that was so devastating. And, I would say that within a few months of recognizing just how unprepared we were, how poorly we as a health system, and particularly the power base of our healthcare system, which remains in acute care, much to our chagrin, how shocked everyone was, from the urologists, to the plastic surgeons, to, the internists. Like, nobody really understood how critical that aspect of our health system is, and how poorly we understood it, and the work we have to do. And that is going to be for climate change, for heat domes, for lower temperature, and for infrastructure issues related to climate change. Like they're still a group, whether they're in their homes or whether they're in our facilities that we run and are responsible for. We have a lot of work to do to mitigate their risk, so that the last years of their life, they're not isolated, they're not so vulnerable, and that we're on top of it in terms of taking responsibility. So I'm going to stop there, and just say, we've learned a lot. The lessons of COVID are directly transferable to the work we have ahead of us to mitigate climate change. We have a lot of resources. We need to steward them and use them. Go for that quadruple word score, and remember that it's our relationships with each other that allow us to be nimble and to make clear and transparent decisions, and be able to revisit them, and bring our colleagues across different sectors or within our own sector along with us. And of all the things in my career that I've learned, that is one of the most critical things that will get you out of a tough fix faster than just about anything else. So thank you so much for the opportunity to participate in this today.
Thank you, Penny, for a wonderful set of comments. And for now, all of us will be looking for the quadruple word score in our day-to-day work. Before we turn, so this is the opportunity now for participants listening out there to submit their questions. And before we turn to the questions, I'm just going to ask Fiona, would you like to respond to the commentaries to your talk very briefly?
Gosh, I hadn't anticipated such an opportunity. Well, no, I mean, I feel like, Penny, you've taken up the critical issues that I was trying to flag of sort of health policy 1.0. We have a great deal before us today. And I think Andrew was very much and more eloquently taking up the questions about how we restructure and reorganize and rethink what we're doing within that set of activities in sort of health policy 2. I guess almost a question that I would have that sometimes makes it hard for me to sleep at night is whether the two are reconciled, whether in fact we are moving collectively in the, are we patching up the burst tire, or are we restructuring? Can we restructure as we fix? Because we need to fix. We need to keep these systems functioning. We need to, the classic metaphor. We need to fly the plane as we build it, right? And I'm very, very involved, and Penny is, of course, sort of our sort of chair for the national action initiative that I'm leading called Cascade. So we're very involved in these sort of active efforts, but I'm also very interested and concerned in the fact that most of it presumes that the world we know will, and in a sense should, continue. So it is rather challenging to do. Those are my thoughts.
Great, thank you, Fiona. So now we'll turn to the questions, and we've got some great questions that attendees have put to us. So the first one has kind of a practical flavor. So what is it actually going to take for hospitals or healthcare institutions to reduce one-use items and other impacts, as well as maintaining patient protection protocols? Can they do it, and how do they do it? Who wants to handle that one first?
Well, I want to jump in because just last week I got into a discussion. I think I told Fiona this about macerators for bedpans versus, sterilized, those old stainless steel bedpans. And I just want to say, even if they were equivalent from a climate perspective, I would go for the old stainless steel bedpans. For women, they're way more comfortable. But we're facing these things every day. We need good science, and we need to, this is where you've got to have the relationships with your supply chain people, with your government capital policy folks who are funding these things, with your hospital planners and with your clinicians, because everyone needs to get on board. And, everyone has an opinion. And in healthcare, my experience is everyone has a veto. And, we've all got to give up our veto and figure out where's the triple and quadruple word score? So I'm for the stainless steel bedpans that will sterilize. My understanding is that they're more expensive in the beginning. Over the long term, they're way better for climate mitigation.
Thanks, Ben. I was an orderly in a community hospital a long time ago. I'm very familiar with stainless steel bedpans. Fiona or Andrew, would you like to comment?
I'll pick up on that one. And I think there are these, what Jacob Hacker called sort of last mile policy questions that are using a supply chain metaphor. There's some things that are really, really close to where the action is, where there are going to be some tough decisions and clinical preference and patient preference and organizational capacity and things like that. But then there's a whole web of things in that literally supply chain that actually will need to be transformed. So if you're going to actually make those stainless steel pans, if you're going to reduce the climate impact, then they need to be reprocessed close. They need to be proximate. The building of the material, the resource extraction, the production, the transportation. So the current sort of habit that we have of mining here and shuttling it in a big ship there to process, and then shuttling it back to put into this form, and then shuttling it back to put in this form, and all the embedded carbon in the cheap labor and regulatory arbitrage is built into our supply chains will actually have to shrink to turn that stainless steel to some extent. Now, there's limits, obviously, to that. We're not talking about autarky, but we are talking about tremendous opportunities, I think, to rethink some of these fundamental issues that are actually about labor standards and environmental standards and the production of the goods and services that we have become so callous about. There is modern slavery, there is child labor in the medical supply chain, and these are things that should and must change.
Thanks, Andrew.
So there's your quadruple word score, Fiona.
There you go. Yeah, absolutely. Yeah. Andrew, did you like to jump in on this one?
Yeah, and it's from some work that with Fiona actually, and one of a graduate student who we both had the chance to supervise, Nada Dali, some of her work that comes to mind, which is viewing health organizations as anchor institutions within communities. And it kind of relates to this idea of a triple word score, the idea of thinking about these organizations as anchors in communities that are rooted in communities and have impact on communities, and considering kind of three buckets of work: the labor actions in the organization and who is working and what their standards are, and their people in the community, the procurement policies of the organization, how can they reflect the community's values, and then thinking about the environmental impact locally, including things like pollution locally and energy use and things like that. And so it's a fairly simple, way of maybe thinking about this, is that if we could shift health organizations away from the current things that have driven them to using single-use plastic, cheap things, and shift it to a different set of metrics and a different way of looking at their role, it could help. And then that would be part of it. Of course, as others have said, there's this technology part. How do we produce something that's reusable, or how do we, and to Fiona's part, how do we ensure the supply chain of it is also considering these values? But this kind of anchor institution idea could be a simple framework for changing, and it's changing how we think about healthcare right now, and healthcare institutions, which are made up of fantastic, really well-educated people who are well-intentioned, but they're being driven by these things like cost containment to make decisions like that. So it'd be changing the way we judge, their activities and understand their impact. Like, it would be amazing if every hospital in Canada put out an anchor institution report that talked about what they were doing and what their role was. It also, I think, would invite the local community to play a bigger role in actually what is happening within institutions.
Great, thank you. So our next question is going to take us up from the practical level to a more metaphysical level almost. So do you think that human beings as a species can collaborate to adapt equitably and sustainably to climate change within the social and technological constraints we live in today?
Mhm.
Where is the quadruple word score for this one?
Really.
Who wants to take a first crack at that?
All I'll say is
Go, Fiona.
who's a fan of David Graeber, who unfortunately and tragically left us in 2021, author of Debt, the First 5,000 Years. And the last book with David Wengrow, who's an archaeologist, was, I can't get the name right, but it's basically rewriting the history of all things. And he's a brilliant anthropologist. And what's wonderful about that book, and I would really strongly recommend it to you, is he just helps us to rethink some of our staid old theories and thoughts about human possibilities and social possibilities, and a sort of a understand the complexity of human communities. We have done many things over millennia. We have tried many things, and many of them have been much, much kinder and gentler and more generous than many of what we are currently, in a sense, stuck in. So I think my antidote to despair about the nature of the human community is David Graeber. So that's my answer to you on that one.
Mm-hmm.
Thanks. Penny or Andrew?
Yeah, I absolutely. I'm with Fiona. I have faith, but it won't just come, because the memos have been sent out. Like we have to kind of nurture that kind of behavior, and the polarity that we're facing, whether it's in politics or just even in leadership, and the competitive aspects, and many of the things that Andrew and Fiona have referred to so articulately. Like we have to learn how to be more forgiving, right? Forgiveness, compassion, not having to know it all. And so I think there's hope, but we've got some work to do, right? We're kind of on the wrong path, and somehow we gotta reverse engines.
Andrew?
Yeah, I agree. I think there's absolutely the capacity, and collectively we have done many things, but it won't just happen. And to Penny's point, I think just issuing a statement or a declaration or something like that it doesn't do anything. And actually, I think there's a whole movement away from this kind of declarative, advocacy to actually, what's going to happen. I think a good example of some of these things are collectively how with mass movements, things like Canadian Medicare happen, things like deep investments in social housing that happened in the 60s and 70s. I think, the establishment of old age security, these things don't happen, really with the people in power or those with wealth, making a decision. They happen when mass movements push them to happen in a collective way. And I think, so I hold hope. I think that our role is often to create spaces to convene, to use knowledge and contribute that and to listen to communities, to really take direction from communities about what should we be studying, how should we be using, public resources for education and for research to drive this ahead. And so, yeah, I think it is possible, and we can start within our institutions. We can start by modeling this locally, like how much do we actually embed these ideas of collective action and democratic kind of decision making within academic institutions, within workplaces like a public health or health authority, within a hospital. So we can actually test it out and try to move that forward.
Great, thanks, Andrew. So your last part of your answer there, Andrew, actually sets up nicely the next question. The Dalla Lana School of Public Health is an educational institution. So what sort of training programs for public health and health systems leaders are available, or what sort of things need to be in the curriculum? And are there opportunities for teachers and clinicians to work together to build sustainable care networks that can help to start this process of mitigation, adaptation, and building resilience? Who wants to jump in on that one?
Mm-hmm. Well, I'm going to start because, you know, at a very practical level, I think that, you know, explicitness about what we're trying to achieve is one of the really important things. You know, I always remember, you know, as a CEO, you always were responsible for the employee survey, and people would come back and, you know, all kinds of, you know, different issues that your staff talked about and said weren't working for them. And, you know, and then you had to get a plan for how you were, you know, your board would say, well, or your city council or your cabinet would say, well, what are you going to do about it? Until you make a plan. But one of the things I learned is that sometimes when you are clearly doing things which address the complaint, people don't recognize it, right? They just, but they don't realize, okay, you said this and describe this and we're doing that. So I think one of the really important things about this is, how do we make sure that people know we're being purposeful about, you know, how we train, how we're trying to work with each other, and what the overall goal of that is. And you keep revisiting the goalposts so people know, you know, we're going through this exercise, and, you know, it's like the quadruple word score where we're trying to learn more and, you know, get a better information base or whatever it is, but also we're trying to learn how to do this so that we're more humble, we have more awareness of our community, and we're better at responding to their needs and, you know, putting in place solutions to these difficult problems. So it's really about purposefulness and explicitness in some ways. I'm just going to throw that in and over to Andrew and Fiona.
Thanks.
I can chime in. I building on your comment, Penny, about revisiting the goalposts. I think that's the way I would think about this question too, is revisiting what it means to be trained in public health. And this is a fantastic time as we're 2 years into the pandemic, where we've learned a lot, like you said, and it's maybe a good time to actually think about what are the key skills that someone in public health needs, and what have we learned with the pandemic, but also, you know, new skills. I have the privilege of training as a public health and preventive medicine specialist, and also, you know, doing a public health degree at in the UK. And I think the focus of much of our training had a lot of focus and really excellent training in technical skills around epidemiology, biostatistics, health policy and understanding it, but less on things like community engagement, consensus building, less on learning from other disciplines, you know, which actually, you know, mentors like Ross actually have really helped me to learn more about. But like, you know, imagine public health training that brought those disciplines more in, and also challenged us more to work in a collective way with basically the folks who, when you go into the field, you're going to be working with. You know, I find that the training, like much of higher education, is often very individualistic and focused. So, you know, those are some thoughts. I also think this is a great time to engage the public in and particularly specific communities, such as Indigenous communities, such as racialized communities, in also what do they seek from public health leaders. It's in the 90s, you know, there was a very powerful movement to ask the public about what do they want from physicians. And this was led by colleagues at McMaster, and then it became, you know, the CanMed's roles, which changed medical education. Because it really, I think, started with the simple question of asking members of the public, what do you want for your physician, from a physician? And I think maybe this is a good time to ask the same in public health. and just expand our way of thinking that you need to have the technical skills, and you need the kind of some of the basic science of public health, but what are the additional, skills? It's also, there's so much to learn in a short period of time. So how do you continue to learn? And how do we make sure that people's skills are being built, and that schools like Dalalana, and other public health institutions can actually offer more to folks once they're in the field as well.
Yeah,
So Fiona, would you like to add to that? Yeah, because we're coming close to time, but
when it comes
you get the last word.
Sure. When it comes to curriculum, I just want to shout out to Poland, and Dalalana has been for years working with Canadian Public Health Association and colleagues across the country on this issue of bringing the eco-social determinants of health into public health education. I think when it comes to health services and policy research and health management, quality improvement, which is more the HPME side of things, I think we're working on that. And I have to shout out to the trainees who've been real leaders in pushing that agenda. So I think I think we're moving, and I think there's more to do. I know that the medical students and nursing students and other allied health professional students have been the ones pushing for curricular change in their respective health professions. And so I think that is moving apace. Continuing professional development is something that we do through Cascades. And then in terms of action, and there's more of that needed, and collaborate a great deal with organizations across the country. I think there's tremendous enthusiasm for action. I think what needs to happen, obviously, I think we need some top-down policy support. British Columbia is miles ahead of other provinces in the country. There's lots to learn from BC. Good example, though, I think of an opportunity to leverage the enthusiasm, collaborate, coordinate, bottom-up push, and that creates the sort of conditions of possibility for top-down sort of requirements. And I think we can, in the tradition of, certainly in Canada, provincial innovation with federal support to spread and share that innovation is the model that I would like to see. And I think there's opportunity to do that.
Thank you. Well, firstly, so there's no questions that admit to a certain yes or no. So we'll have no short snapper round. And unfortunately, we're at time, but this gives me the opportunity to thank Professor Miller for an exceptionally stimulating keynote, and Drs. Boehm and Pinto for their very insightful and thoughtful comments. So thank you for those amazing contributions. It's been a wonderful seminar. But it's also time to thank everyone in the audience for taking time from their busy lives to attend. And on behalf of the Dalalana School of Public Health Advancement and Alumni Engagement, thank you for taking time in your day to come to the Boehm Lecture. I want to remind everyone that the event will be posted to the Dalalana School of Public Health YouTube page immediately following this event, and it will contain the closed captions. I encourage you to, so there are a large number of questions that remain unanswered, as it is in life in general. But if you would like to, you could contact the panelists in the keynote and follow up with your question if we didn't get to it. And remember to stay in touch. Follow the Dalalana School and IHPME on Twitter, Facebook, and Instagram. And we hope to see you at the next event sponsored by the Dalalana School. And Steny, would you like to say a final goodbye and thank you?
Hey, thanks to everyone. Thanks for spending so much time on such a critical topic for us as we think about the future of our health system and really the future of our planet. And I'm really grateful that we can use the Boehm Lectures to tackle such really critical issues. And so I'll just close by saying thanks to Les as well for all of the support of this. Great. And Ross, thanks for a great job moderating.
Thank you. Thank you for the pleasure and privilege of being the moderator. So take care and be well, and we'll see you at the next event.